Everyone. Today I'm going to be talking about how pharmacogenomics is being used and, in some cases, how it's still being developed to improve testing and treatment for systemic lupus and erythematosus. Also, I'm going to be pronouncing a ton of words incorrectly, so warning before that. Um, Instead of saying systemic lupus erythematosus every single time, I will most likely be referring to it as SLE. I'll be covering the main genetic markers that have been studied and how they compare to traditional dosing approaches and what the research actually shows, the ethical issues we need to think about, and what the future looks like. So, what is pharmacogenomics? Pharmacogenomics looks at how differences in our genes affect the way that we respond to certain medications. The reason that this really matters in lupus is because treatments often involve strong immunosuppressants, and patients can respond really differently to the same dose. Instead of using a really slow trial and error approach, pharmacogenomics has the potential to guide dosing more accurately from the start. So, why does it matter for lupus specifically? In lupus, accurate dosing is absolutely crucial. Too low of a dose can lead to a disease flare or kidney damage, whereas too high of a dose can cause toxicity. Pharmacogenomics can help explain why two patients on the same medication may have completely different levels of drug exposure. This helps us think about personalizing treatment instead of relying on that one size fits all dosing. Now let's talk about some tech and genes that are being studied. Most lupus pharmacogenomic studies use tools like genotyping panels, PCR tests, or genome-wide association studies. We also call this GWAS. These methods look for single nucleotide polymorphisms, or SNPs, like we learned about in class, that influence drug metabolism. Some of the major genes studied include CYP3A5, which affects tacrolimus metabolism, which is a drug often used to treat lupus. There's also UGT1A9 and UGT2B7. Sometimes it's referred to the UGTs, and this helps clear mycophenolic acid, which can occur when taking the medication mycophenolate. Next, we have TPMT, which is linked to azathioprine toxicity, again, another immunosuppressant drug, and ABCB1 and ABCC2, which are drug transporters. And understanding these genes help predict who needs that higher dose or lower dose, and who might be at a greater risk of side effects. One review by Ali Rahmat and colleagues in 2025 summarized all the pharmacogenetic evidence available for lupus treatments. They found strong theoretical support for several markers, like the CYP3A5 for tacrolimus and the TPMT for azathioprine. But they also found that most research comes from transplant patients, not from people with lupus. The takeaway here and the reason for including a review in my presentation is that pharmacogenomics shows promise, but we still need more lupus-specific studies before making it a universal standard. I'm now showing a second study that looked at a biologic called belimumab, which was also used for lupus. This is a large genome-wide association study, but it didn't find any strong genetic markers that predicted who would respond better to the drug. Even though we have a negative result here, it's still important because it shows that not every lupus medication has a clear genetic predictor. It reminds us that it's important not to overinterpret genetic data before evidence is actually ready. Another major area of research involves tacrolimus, especially for lupus nephritis. Gleason and colleagues found that patients who expressed the CYP3A5 enzyme metabolize tacrolimus faster, so they need higher doses to be able to actually reach therapeutic levels. This is directly useful because tacrolimus dosing can be really difficult. But even here, the study did note issues like cost of testing and the need for dosing guidelines based on lupus patients specifically, not just transplant populations that were used in the data. Another really interesting study is done by Ye and in pediatric lupus nephritis, Ye and his colleagues showed that mycophenolate levels vary very widely between patients. Some of this variation is linked to genes like UGT1A9, CES1, and ABCC2. However, body weight was still the strongest predictor overall. So the best approach may be to combine genetics with traditional weight-based dosing and therapeutic drug monitoring. Because this is pediatric research, ethical issues around consent and equity are especially important to keep in mind as well. As with many topics in pharmacogenomics, there are several major ethical issues that we do need to keep in mind. First being access. Not all clinics or communities are going to have genetic testing available, which could widen existing health disparities. Secondly, there's ancestry bias. Many studies are based on mostly European participants, which means results may not apply equally to all populations. Next, we have privacy issues. Genetic information lasts a lifetime, so patients need to understand how their data is going to be stored and used and who is going to have access to it. Finally, clinicians have to be careful not to overpromise what pharmacogenetics can do until the evidence is stronger. Looking forward, the field needs larger, multi-ethnic studies that focus specifically on lupus rather than other conditions. As we saw before, studies that use transplant data aren't a great reflection of our lupus patient population. We'll likely see more work combining genetics with therapeutic drug monitoring and other biomarkers. As testing becomes cheaper and easier to access, pharmacogenomics could become a routine part of lupus care, making treatment safer, more predictable, and more personalized. In summary, pharmacogenomics has real potential to improve lupus treatment, especially for drugs like tacrolimus and mycophenolate that show strong genetic influence. The field is promising, but still developing, and ethical issues around access and equality need to be addressed. With continued research, pharmacogenomics may play a major role in precision medicine for lupus. Thank you, everybody, and thank you, Dr. Wilmington, for this semester. I've really enjoyed it. Hope you guys have a great winter break.